That does not allow us to create more monsters. Having said that,
So the answer is yes, that your feeling is the same way toward radiology, pathology,
I will clarify it.
anesthesiology.
I will clarify what I mean. Radiology, pathology, and anesthesiology, these were made into closed contract at a time when there were not enough specialists available. But now there are a lot of specialists available. Secondly, radiologists, every subspecialist in the field of medicine knows radiology. So the radiologist cannot just say there is no fracture in the bone. When, as an orthopedic surgeon, when I look at it, I discuss with him and tell him, look, there is a crack here. What do you think it is? And there is a peer review that way. Anesthesiology, the anesthesiologists work under the supervision of the surgeons. Every surgeon is peer reviewing the anesthesiologist. Pathologist, I'll tell you an example. A young lady, school teacher, 2 years ago was sent to me. She had a chest x-ray and there was a small lymph node in her mediastinum or behind the breastbone. Was sent to a surgeon. He goes behind the breastbone, picks up some tissue as a biopsy and gives it to the pathologist. Pathologist looks at it, tells the surgeon, this lady has got a rip-roaring carcinoma, malignancy. She's going to die in 3 months to 6 months. Go and tell the family. The doctor goes and tells the family and the patient. You can imagine what the status of these people are. And this patient was so uptight because only small piece of this single thing was taken out. She was referred to me to look into it. I repeated the CAT scan of the chest. There was still that lymph node, but there is swelling now because of the surgery. So I told her, let's calm down. Get me all the reports. I'm going to cut short the story. We got all the reports. I wish I had a glass of water. I'm sorry. My mouth is drying.
Sergeants, could I ask that one of you bring the witness a glass of water? And then we'll...
Please don't poison it. Pardon me. So, this lady, I looked at it, went through the whole process. I discussed with the radiology friends of mine. They all said, my God, there is no cancer. This is just an ordinary inflammatory lymph node. So, okay, please bring me bring the slides. We got the slides. I sent it to 2 sets of pathologists. They all looked at it. They said, there is no cancer here. Thank you very much. There is no cancer here. This is a benign process. So, exclusive contract, no peer review. This is not the way to practice medicine. This is not quality of care. And I tell you another example.
We need to move on to the next witness. You've exceeded your time limit. Okay. Dr. Onnested, you wanted to make a comment on an earlier question, then we move on to Dr. Salimpour.
Just to answer your question, exclusive contracting includes the ability of the closed department to police itself. In my hospital, we have a closed department with anesthesiology. We on the Surgery Monitor Committee have not reviewed any anesthetic deaths in over 4 years because they are policing and peer reviewing themselves. And exclusive contracts contain the ability of a department who's closed to do just that, and they are outside of the regular review process unless something happens to the point where the rest of the medical community becomes alarmed. The ultimate responsibility still goes with medical staff, and yet exclusive contracting also gives with it the ability to have your own peer review within the department.
Okay, thank you. Dr. Salimpour, welcome.
Thank you, Mr. Chairman. Ladies, gentlemen, thank you. My name is Pejman Salimpour. I'm a board-certified pediatrician. I practice in Los Angeles. I'm on the board of directors of the Cedars-Sinai Health Associates. I've been clinical chief of pediatrics at Cedars-Sinai Medical Center and many pediatric programs in Los Angeles. Senate Bill 817. I got home late last night, ladies and gentlemen. Despite serious objections by my wife, my 3-year-old daughter was waiting up ready for me. As soon as I opened the door, she ran to my arms, jumped in my arms and said, "Daddy, read me book." And ladies and gentlemen, this is the book she showed me. Little Red Riding Hood. Senate Bill 817 is a wolf hidden in the clothes of a grandma. This, ladies and gentlemen, is Senate Bill 817. This is Senate Bill 817, not what you've been presented. Providence St. Joseph Medical Center just presented my partners, who happen to be both certified neonatologists, a contract to sign. It's called a non-exclusive neonatology contract. It relates to the latter part of Senate Bill 817. This is 817. 817 is not some vague bill you've been proposed. This is 817. And this is what it says, ladies and gentlemen. It says, a physician who they're contracting with may perform professional duties as dictated by hospital administration rather than by the medical staff. Well, I'm not an attorney, I'm embarrassed to admit, and I know not nearly as much as the hospital attorneys present here today about case law and law. I do know one thing. We are not a corporation. A hospital is a tax-exempt, for the most part, institution. You and I subsidize it. It is not an IBM or a Microsoft. It's not a GM. We are not employees of the hospital. I am an employee of my patient. Why should I be accountable to a hospital administrator rather than to my peers, to the medical staff? It also says, and I quote, the physician is subject to an annual review by hospital administration. And I quote again, the physician is required to participate in all third-party payer programs. I'm not an attorney, but the CMA attorney have said that this is against Health and Safety Code 1322, which expressly provides that hospitals shall not determine as a condition of medical staff membership acceptance of all third-party contracts. It also says, this is beautiful, it also says that the physician is subject to termination. The one that's signing the non-exclusive contract, mind you, not the exclusive contract, the non-exclusive contract, is subject to termination without cause on 30 days' notice, end quote, in flat contradiction to well-established rules prohibiting termination of medical staff membership or privileges without good cause following fair procedures. It also subjects this contract to additional miscellaneous provisions which reinforce the unfairness of this contract. Ladies and gentlemen, talk is cheap. We can all sit here and say beautiful says, beautiful stories about how we're going to improve care, quality, access, on and on, just beautiful, gorgeous words. This is real 817. This is what 817 is all about, ladies and gentlemen. You see, my odyssey started about 2 years ago.
Dr. Salampur, your time has expired, so I need you to sum up and complete your remarks, and then we'll take any questions from the committee.
Thank you, Mr. Chairman, and I'm very grateful for the opportunity to appear here before you and members of the committee. I have one last thing to say. A change in law is a major thing. Thanks goodness, thanks God, that we have people like you to make sure that the laws are not changed hastily. We've been told that there's been debate over the past year about this, that there's been lots of discussion. Well, I was presented with this last Thursday afternoon, and a great many of you have been out of town. And now you are asked, ladies and gentlemen, to vote on this. A bill that's way too complicated, that deals with way too many new issues. Peer review. Who is going to peer review physicians who hold these exclusive contracts? And what is this new type of contracting that's never been heard of before in California? Non-exclusive physician contract. Thank you. And thanks again, Mr. Chairman, Dr. Gallegos, ladies and gentlemen, for the opportunity to appear before you.
Thank you, Dr. Salampur. And just to address one point in your remarks, Dr. Salampur, this is an issue that has been around, and I've mentioned this earlier, for the better part of a year that this legislature has been dealing with it in both houses. There have been 3 bills, including your sponsored bill, sir. So this isn't an issue that just came up on Thursday afternoon, with all due respect. This is an issue that the parties have been involved with for a great deal of time, have put a great deal of effort and energy to reach this point, and I think they've reached the point where we have a solution, and I think the solution is in this bill. Now, does everybody agree with it? Of course not. But I think in this bill, in my interpretation, and I'm not a lawyer either, Dr. Salimpour, a lot of what you were bringing up in that contract that is current practice is going to be dealt with and prohibited in this bill. And I see the Senator acknowledging that, and I don't know, Mr. Weisberg.
This is a new bill that we're going to witness, or the one you're referring to right now?
Well, 817 is a new bill.
Right, it is.
The language is
The
new, it's not a
language
new
of the bill,
bill.
Dr. Salimpour, would make that type of contract illegal.
Exactly.
But I was just presented this contract with all due respect last week.
Well, sure, that's why we're pushing
Because my bill hasn't become law
817.
yet. You ought to maybe endorse my bill.
That's why we're pushing SB 817, because that's going to prohibit those kinds of contracts
With all due
when this
respect,
bill
Dr.
takes law.
With all due respect, Dr. Gallegos, that's not what the attorneys at CMA and others say. They say that this is what we're told, non-exclusive contract, and that this
Well,
is SB 817.
Everyone's entitled to their opinion.
I apologize.
At any rate, let's move on. The rest of the opposition witnesses, you want to step forward, identify yourselves. Oh, I'm sorry, Jim. Yes, you've been seated there. Go ahead. But we've heard from the witnesses, so we just me too's at this point.
Certainly. Jim Ranlett, I'm representing the California chapter, American College of Cardiology, and the 2,000 cardiologist members of our association are opposed to this legislation. I noticed that the witnesses didn't get a chance to respond to Mr. Cox's question, and to do that from the perspective of the patient, Mr. Cox, and an example that occurred in the North Bay of San Francisco is the cardiologist group there at a hospital that had a heart surgery program, the only program in the area. They attempted to influence the cardiac surgeons that had an illegal but still exclusive contract at the hospital to do a less invasive procedure at the hospital because they thought it was less invasive, less harmful to their patients. The cardiac surgeons who had this exclusive contract refused to do this. They thought, well, we don't really want to be trained in this. They asked to call in a surgeon, heart surgeon, very well qualified from San Francisco, and that was refused by the hospital because these people had the exclusive contract. So the point is that this cuts so it can hurt the patient, and we believe that this bill will not help patient care. Any quality standard that you could impose with an exclusive contract, the medical staff can do today by setting the standard.
Okay, thank you very much. The remainder of the witnesses, please identify yourselves, state your position for the record, and then we'll move to a vote on this bill. John?
Mr. Chairman and members, John Valencia, representing the California Dermatology Society and its core of dermatologic surgeons. The point raised by Mr. Wayne is principally the reason that we oppose the bill, page 4, and the standards raised for the economic reasons that Mr. Cox raised. Thank you.
Thank you, John. Trish? Or Mark? Go ahead.
Mark Segman, representing the California Academy of Family Physicians and also the American Medical Group Association. Pursuant to Mr. Cox's question, there are examples of exclusive contracts actually raising the cost of the medical groups.
Mark, I asked just specifically state the position for the record. We've heard an hour and a half worth of testimony, so I think we're ready to move on this bill, one way or the other. You're opposed?
Yes, sir.
Okay. Trish? All right. Go ahead, Mark, but bear in mind that I stated the rules very specifically at the beginning of the hearing. These are rules we've used for 4 years in this committee with regard to the timing of testimony. I know you're new here, Mr. Cox, but those have been rules of this committee for 4 years. Mr. Sexton? Well, no, you asked, and I granted that liberty, so Mark, go ahead and finish your comments.
I apologize. Councilman Cox, the question is, there is a situation that I'm familiar with in the Upper Desert where there's an anesthesiology group that has an exclusive contract with the hospital. Because it is the only hospital in the area, they are able to charge much higher rates for the anesthesia service, and the medical groups that contract with that hospital have, in essence, no other place to go.
Next.
Tricia Hunter with the American Nurses Association, California. We don't do open heart surgery, but we have found exclusive contracting a way to block out advanced nurse practitioners, and we do not want to see it expanded. As a cardiovascular nurse, I could go into a lot more, but I will respect the chairman and not do so.
Okay, thank you very much. Any other witnesses in opposition? Okay, seeing none, are there questions, any further questions of the witnesses?
I'm not done.
Senator, you may close. Oh, I'm sorry, Ms. Kuehl.
I, like all the members of the committee, have been listening and listening. And I'm very troubled, actually, by the opposition. I intend to vote for the bill. And as a matter of fact, I was prepared to offer an amendment to include neonatology as one of the specialties that could be included in the bill, because from personal experience in my family and meeting with groups of neonatologists on both sides of this issue over the past 2.5 years, I've become convinced that it's exactly the kind of specialty that should be included. However, given the fact that we've had such discussion and a bit of controversy about the bill, I don't want to, out of respect for the author, weight the bill any further, or even make the point that it's a slippery slope by my actions, because it's not your intention to do so. But I do feel that there are specialties in which it is absolutely appropriate that doctors should be able to contract with the hospital and be there and know that that's their hospital. I know doctors that are driving between 5 hospitals. I don't think that that serves the patient all that well in these areas where we might have emergent services necessary, where we might need to have relationships established in the hospital. I'm very troubled by the argument that doctors' livelihoods will be put at risk. With all due respect, I don't care. I care about the patient's safety, care about the patient's ability to be able to access the best kind of services. I certainly don't like the idea that anesthesiology costs more at a hospital that has an exclusive contract, but I'm not sure I like the idea that I'm going to get the one that costs the least either. That's been one of the problems, I think, created in the whole area of managed care that we've become very concerned about. I'm not a doctor, I'm just a lawyer. And I am also, on occasion, a patient or a relative of a patient. I think that the bill is drawn very narrowly. I think that it serves a purpose when you look at the specialties that are included. I do appreciate some of the testimony of concern about strengthening the standard upon which the hospital will be required, the hospital administrators will be required to consult with the medical staff, because those opinions would be extremely beneficial and necessary in making these judgments. But I do intend to vote for the bill. I think that I think it's been very interesting and full testimony on both sides. And I'm sorry that I don't have a question, Mr. Chairman. Just wanted to make a statement. Thank you.
Thank you, Ms. Kuehl. Senator, if there are no further questions, you can close.
Thank you, Mr. Chairman and members, for a very thorough discussion of a very complicated issue. Today, the law says you can have exclusive contracts in perpetuity. They could last forever. What this bill does is to contract that, is to only identify certain practices as to be within the realm of exclusive contracts. How did we choose those practices? Because there's a body of research already that indicates that this type of practice and the services being based on site helps towards one thing: a better medical outcome for the patient. Yes, if we were to consider neonatology, yes, we're going down a slippery slope. But however, if research should indicate that perhaps that should be also another practice that should be within the exclusive contract status, I am not philosophically opposed to that, but I need to see the research that proves that, because once you start opening the door, then everybody else wants that exclusive contract status. So the ones that I chose right now, the research backs it up. And also, it goes a great way towards what we have right now, which is basically You know, everything tends to be pretty kind of willy-nilly, and there's a lot of exclusive contracting going on without any kind of standards to guide us. The primary standards that I have here guiding us is, will there be adequate coverage in terms of these doctors being available nights and weekends and on call? And number two, will we have medical outcomes, you know, for good medical outcomes for the patients? Those are new standards that we don't have to follow even right now. So I'm adding new standards in order to achieve that outcome. Second of all, do the exclusive contracts under this bill last forever? No, they do not. They can only be for a maximum duration of 3 years, and then after that, they would be subject to a performance review, which is a peer review. They would also be subject to an analysis as to whether there's a necessity for that service. And then finally, there will also be the consultation with hospital staff. I think that I have gone as far as I can go in obviously what is an area that will be subject to a lot of, you know, Monday morning quarterbacking and whatever, but the fact remains that we've been at this for over a year now, and the fact remains that we need to add some certainty to the process. Many people don't like the certainty, you know, but I would much rather prefer to have the certainty if I know that that certainty is going to give me a good medical outcome for the patient, and it's going to get coverage, you know, of services that are perhaps not covered, that are not provided right now at hospitals. Having said that, I thank you all for your wonderful attention to a very complicated matter, and I respectfully request an aye vote.
Senator, before we go to a vote, I would just want to add briefly that I know you've come as far as you can go, and quite frankly, I think you've come a long way from where we were last year. That's why I support the bill. Thank you very much for allowing me to co-author the bill with you. I think it's a good bill. It just needs one more small, though, technical amendment that was alluded to on comment 8 of the analysis that I believe you have agreed to accept.
That's correct. I'm sorry, Mr. Chairman, I gladly accept those as author's amendments.
Okay. Members, without objection, will accept those amendments as author's amendments. The motion will be do pass as amended to appropriations. Ms. Kuehl moves. Mr. Firebaugh seconds. Will the Secretary please call the roll?
Gallegos?
Aye.
Gallegos, aye. Bates? No. Bates, no. Honested? No. Honested, no. Corbett? Cox? No. Cox, no. Firebaugh? Aye. Firebaugh, aye. Kuehl? Kuehl, aye. Runner? Thompson? Thompson, no. Vincent? Wayne?
Aye.
Wayne, aye. Wesson? Wesson, aye. Wildman?
No.
Wildman, no. Zettel? Zettel, no.
Senator, that bill has 5 aye votes. It needs 3 more. We'll put that bill on call. As you can see, we have some members who are not here currently. We have 1 absent, Mr. Vincent. He's not been replaced. Let me just, members, while we're at this, let me tell you what the rules for reconsideration are, Senator, just in case you're interested as well. Reconsideration's not automatic. If a bill fails passage, we won't grant reconsideration automatically. An author, well, why did you give me this? An author, Senator, must request reconsideration, and it must be approved by a majority of the committee. Okay? I don't think there'll be a problem, Senator, if we get to that. Hopefully we won't have to, but just wanted you to be aware. Okay, members, on to the next easy bill that we have, which is item number 4, AB 1800 by Assemblymember Thompson. Oh, no, I'm sorry, Helen. Ms. Zettel, you had a bill, item number 2, AB 1748. You were going to present some amendments on that? Okay. Members, Ms. Zettel is going to come forward with her bill. She's going to have some amendments to present, and then this item is going to be placed on the consent calendar without objection, but we just wanted to get approval of the author's amendments.
Thank you, Mr. Chairman and committee members. I'd like to author amendments for AB 1748, which adds language to clarify immunization record sharing and removes language calling for the contracting of an outside agency to perform immunization services functions. These amendments remove the concerns expressed by the oppositions. We also have another support on this bill. The American Academy of Pediatrics has come on board in support.
Okay, great. Members, before we go to you, Jim, members without objection will accept those amendments. They are in the analysis as authors' amendments. Okay, without objection. Jim?
Jim Gross on behalf of the County of San Diego. I actually been working with 14 counties who operate these immunization registries. More counties want to do the same. The Department of Health Services has also been involved in the drafting of the language. I think we have an important bill here, and we ask for your support.
Okay, thank you. Any other witnesses, support, or opposition? I don't think there's any opposition. Without objection, members, then item 2, AB 1748, will be moved to the consent calendar. Hearing no objection, such is the order.
Members. Thank you, Mr.
Okay. That was the easy bill. Members, without objection, I believe we had requested early on to substitute the roll call for consent calendar. So without objection, we'll reiterate that at this time. Item number 4, members, AB 1800. Assemblymember Thompson. Assemblymember Thompson, welcome. Good afternoon.
Good afternoon, Mr. Chairman and members.
Assemblymember Thompson, as per our discussion before you begin, as per our discussion earlier, we are going to hear the bill today. As I understand, the bill will not be taken up for a vote today, but rather will be put over and would allow the ability and opportunity for committee staff and your staff to work on some amendments on some areas that we feel we still have some concern with before we move the bill out of committee.
And our goal would be to make the next Health Committee meeting.
That's going to be our goal, correct.
Okay.
The next Health Committee meeting is March 28th.
Thank you very much, Mr. Chairman. You are receiving amendments that are being offered today, and I believe my staff has talked to your staff about them. These are amendments requested by Speaker Villaraigosa, which do the following. Deletes the language in the bill that would be interpreted to give the counties the option of denying services to those who qualify, and adds language to clarify that the assisted outpatient services in the bill are available to all severely mentally ill patients, regardless of whether they initially entered the system voluntarily or involuntarily. With regard to concerns that have been raised by the psychologist, we'll work together to have language that meets with their approval, I hope. It is not my intent to make this a scope of practice issue. There is more than enough work in California for anyone who practices in the mental health field. So with those amendments, I'd like to just proceed to...
Ms. Thompson, on those amendments, we just received them a few minutes ago. Committee staff has not had an opportunity to analyze those. If we can hold off voting on those amendments until the next hearing, we'll take it up with all the other amendments at that time, and that would provide an opportunity for committee staff and for the committee members to see those amendments analyzed.
That's fine.
Okay, thank you.
I'm showing my goodwill by providing you with some amendments that I hope will clarify. But I do want to...
Certainly are, we appreciate that.
I do have a statement, if I can find the right pieces of paper here, and then we'll proceed. Thank you. Mr. Chairman and members, today in California, on March 14th, 2000, our safety net for the mentally ill is either jail or prison. Currently, there are 4,000 mentally ill persons in our hospitals, two-thirds of whom have been judicially committed, and there are approximately 27,000 severely mentally ill persons in our state's jails and prisons. The criminal justice system, I believe, is the wrong place to provide services to the severely mentally ill. It's the post-LPS version of warehousing. Instead of, as in the past with our state hospitals, today we warehouse the mentally ill in our jails and our prisons. The money we spend on mental health services there could expand model outpatient programs to every county and make a continuum of care services available to the mentally ill statewide. The 30-year-old Lanterman-Petra Short Act provides for the involuntary commitment and treatment of severely mentally ill people only when they have lost the ability to provide for their own food, clothing, or shelter, or about to seriously hurt themselves or someone else. Today, nothing short of that extreme emergency condition qualifies a severely mentally ill person for today's compassionate intervention. It is a cruel distortion of the concept of liberty to leave seriously mentally ill persons untreated, to fend for themselves on the streets or in our jails and prisons. It is a tragedy for the individual, for their family, and for society that AB 1800 seeks to change. Last week in Woodland, a woman was found after 4 days dead in her car, homeless and with a history of serious mental illness. Untreated severe mental illness affects that part of the brain that enables a person to think rationally, to understand they are mentally ill, and to seek remedial treatment. As persons with untreated schizophrenia, bipolar disorder, major depressions, and other severe mental illnesses become increasingly decompensated, their brain becomes more resistant to treatment, and there are fewer options for effective treatment. And in fact, the new research is showing that with each time a person becomes decompensated, their functionality does not return to the same level as it was prior to that episode. In contrast, people with mental illness who have sought treatment voluntarily at a more functional stage in their illnesses are often treated exclusively on an outpatient basis. While outpatient services vary from county to county and may not provide the access and quality that they should, they are an option for those who go willingly. Since people with severe and persistent mental illness often receive involuntary treatment under the LPS Act today, their treatment is exclusively on an inpatient basis until released, often without any assistance or follow-up or assurance of community outpatient treatment. More often than not, they stop taking their medications thinking that their symptoms are controlled, they fail their appointments, and soon are back on an involuntary hold when their chronic illnesses reoccur. And at a hearing in Los Angeles the summer before last, Supervisor Mike Antonovich had 5.5 hours of testimony from families and from clients about the experiences they were having in the LPS system, and that was the genesis of this bill, as well as a hearing that the Select Committee on Mental Health held last February on the criminalization of the mentally ill, a report that you all have somewhere in your offices. AB 1800 would provide earlier involuntary intervention and offer involuntary patients the option to be treated in a community setting once stabilized. The bill provides earlier treatment by expanding the definition of gravely disabled to allow the consideration of a prior history of mental illness. Now, many of you know that I had heart surgery in November. I am now a cardiac patient, with chronic heart disease. I want the doctor in the emergency room to know that I have that disease if I am brought there to be treated. This mental illness is the only illness in our society for which we do not ask nor consider, is there a past history? The science and the research in the past 30 years has provided us a body of knowledge to change that, and it's about time we did that. It appropriates $350 million in increased funding to ensure the aggressive aftercare that is necessary. It lowers the burden of proof at trial for determining grave disability or danger to others to the federal standard of clear and convincing evidence. Now, we are working on that issue with Judge Scrabo in Los Angeles, who is a jurist very well versed in the issues of involuntary commitment. He runs Court 95 in Los Angeles County Superior Court, or Consolidated Court now, and is on the Judicial Council monitoring the progress of this bill. We understand there's an issue here we need to resolve. It combines the current two 14-day holds into one 28-day hold, following the initial 72-hour period of the probable cause hearing that has already established that a patient requires treatment. It extends the post-certification period to 1 year for those persons who have demonstrated to be dangerous to others in order to provide more consistent and effective treatment, similar to that provided those in conservatorships of grave disabilities. Why should those who are dangerous to others be held for less time than the gravely disabled? It requires the same definition for grave disability to apply for involuntary treatment in our prisons. And that's because in prison you are already provided with food, clothing, and shelter. This bill provides, I believe, a more effective safety net for people who are severely mentally ill, and it serves as a mechanism for supportive transitioning into the community. AB 1800 would allow severely mentally ill people who voluntarily participate in whatever improvements we make in services statewide as accessible as those to those who would enter the system voluntarily. You have to understand that whatever improvements we make, and God knows we need them, there are people who cannot access that system of care voluntarily. And you'll hear some of the stories today. Today I have with me some wonderful people who are here to testify. I have Dr. Bob Lieberman of Los Angeles, San Francisco Supervisor Amos Brown, and Mrs. Anna Warner of Sacramento, who will tell you some of their experiences in trying to access the system of involuntary care in California today. Dr. Lieberman.
My name is Dr. Robert Lieberman. I'm professor.
Just push the button.
Okay. My name is Dr. Robert Lieberman. I'm professor of psychiatry at UCLA School of Medicine, where I direct a federally funded research center for the study and treatment of schizophrenia and other disabling mental disorders. I have devoted 35 years to developing new and better treatments for people with mental disabilities, validating those using research methods, and disseminating them to practitioners throughout the United States. Rehabilitation methods that my colleagues and I have developed are now used in all of the states and in countries in Europe, Asia, and South America. One of the common denominators of these methods is that they are emphasizing the importance of educating patients and their families, getting them to collaborate, working with them as partners in the treatment enterprise. I've participated in treatment services in mental health centers and communities here in California, in state hospitals, in veterans hospitals, and in private practice. The inspiration for my work is based on a strong conviction that the possibilities of recovery and a return to a reasonably normal and good quality of life must be based on consumer-oriented, accessible, comprehensive, and well-coordinated treatment services. However, just as in other fields of medicine, treatment services have to be individualized and linked to the phase and to the type of the illness or the disorder. AB 1800 expands the accessibility of treatment and entry into treatment for a wider group of patients, a select group of patients that broadens the number who can take advantage of the effective services that are now available. Individuals who now fall between the cracks of treatment and the prevailing legal regulations of mental health care. I'd like to make 3 points in my testimony, which I hope will aid you in your deliberations and decisions about AB 1800. I do so not only as a practitioner and researcher in psychiatry, but also as a consumer of mental health services myself, a member of the California Network of Mental Health Clients, and a person who's been on both the giving and the receiving end of treatment. The first point, there's no question that mentally ill citizens of California need more and better quality services, but services have to be fine-tuned to the specific needs and types of illness of each person. Epidemiological studies that have been done around the United States indicate that less than half of individuals with schizophrenia are in treatment at any one time. While
that's close to time. Could you wrap up, please?
Okay. Let me just mention the other 2 points I want to make. The second point, in addition to the need for broadening and expanding services, is that there are problems in the central nervous system of some individuals with schizophrenia that make it difficult for them to use basic brain mechanisms such as memory, attention, decision-making, and have insight into the nature of the illness that is affecting them. The handout that I've passed to you has examples of research from brain imaging that shows these abnormalities and shows also that treatment can rectify, to a certain extent, some of these abnormalities, enabling people to move from involuntary to voluntary care. And finally, I would like to emphasize the fact that early treatment and intervention for people with schizophrenia are vital for preventing the chronicity and the refractoriness to treatment later on in the disorder. And that with early and prompt intervention with a wide array of services that this legislation will expand, approximately 50%, I believe, of individuals with schizophrenia will be able to recover. The new treatments that we have, medications and psychosocial services, can make a difference if people can be brought into treatment, and those individuals who are currently outside of the treatment area are given a chance to benefit from these new services.
Thank you, Doctor. Next witness.
Supervisor Brown from the San Francisco County Board of Supervisors.
Thank you, Assemblywoman Thompson. Mr. Chairman, members of the panel, I am here as not just a member of the Board of Supervisors of San Francisco City and County. More importantly, I'm here as a Christian pastor, having served in the faith community for over 35 years all across this country. And I feel that the issue that has been brought to our attention by Assemblywoman Thompson is one whose time has come. For too long, we have neglected to provide a sensible, rational, responsible, civil, and decent approach to providing services for persons who could not think to help themselves, who could not do to provide for themselves. And I just feel, as a decent human being, it is inhumane for us to permit to happen what is going on in many of our inner city communities in this nation today. In San Francisco County and City, 40% of the homeless persons are mentally ill, according to documentation from our health department. San Francisco, that beautiful city that many people talk about coming and possibly leaving their hearts there, has been inundated with aggressive panhandling, defecation, urination, all kinds of unbecoming behavior that is not becoming, in my estimation, of a city. A city was established historically to provide care for the citizenry, to enable business persons to engage in commercial activities, and for the people as a whole to celebrate their cultural uniquenesses. And it just becomes problematic in our city for us to maintain our industry, particularly of tourism, when we have the unfortunate situation of homeless persons who, I repeat, are mentally ill on the streets, creating problems for themselves and for others. Last year we had nearly 200 people who died on the streets, and for the most part they were mentally ill. But what happens when they die there? Because they did not access services, or services were not provided for them. We are blamed for it, and many people hold their heads down in shame. I think it is time now for us to stop playing the game of blaming and to do something. While the questions have been raised regarding some of the technical issues, and definitely I'm one who would not want to violate anyone's civil rights. I was birthed in the civil rights movement, and I believe in civil liberties. But I think that we must come to the point of seeing that when people are in danger, when others are in danger, when business cannot operate, it's time for public policymakers to do the right thing. And I hope that given whatever amendments that will come forth that have been mentioned, that we will stay the course and make sure that we amend our ways of dealing with the problem of mental illness in this state.
Thank you, Supervisor.
Thank you very much, Supervisor Brown. I believe you have in your packets a resolution from the Board of Supervisors in San Francisco, which is a unanimous resolution in support of the bill. Ms. Warner? Anna Warner is from Sacramento.
I'm kind of nervous, so I hope you'll bear with me. I gave you a packet. It has pictures of my daughter in it. My daughter's a wholesome, all-American girl. I could go on for hours, but I'm not going to because I know there's a time limit. She's in Patton State Hospital right now. For over 10 years, I begged people in the different hospitals that when she was picked up, I begged police officers, I begged everybody to please let my daughter have the care that she needed. And she didn't get it. And progressively, she's gotten worse. When she was first picked up back in the early 90s, she was just barely mentally ill. Now, she's so psychotic that she does things that are dangerous, and I had to have her picked up. She has delusions. She believes that she has computer chips in her brain and throughout her body, that she's controlled by them, that computer programs are presented to her in her brain that she has no choice but to act out. She's been 51-50'd many times. Once she broke into her ex-boyfriend's house to hurt his wife. She was delusional. She was on a mission. She was going to save him, and I'm not going to get into that whole convoluted delusion. But believe me, it was interesting. She was 51-50'd. She was turned loose before the 72 hours because she did not fit criteria, which is being a danger to others, a danger to herself, or gravely disabled. Another time, I brought her home because she was homeless. She attacked me out of a delusion. She stood there and she argued with the voices, but the program told her to attack me, and so she attacked me. Another time, I thought that she surely would be treated. She broke into her ex-boyfriend's house twice. She was in the hospital. She had been 51-50'd, 52-50'd. I made up a little book here that I took and gave to the social worker. I gave it to the doctor. I told them, don't let her loose, get her on medication. Because some of the things that she had written in there were that she was that she had a death threat against the husband or against the ex-boyfriend. Another time she said that these things that she was doing, she says, I have never been more out of my element than discovering that I have to take a hand in executioning. Damn you for making me enter this realm. This is the voices that she's hearing that are telling her to do these things. I consider that when a person is denied being able to have proper medical attention because they belong to an exclusive particular group, I believe that is stigma and discrimination, and people shouldn't have that. So I brought this here. It shows what discrimination and stigma is. My daughter now is in Patton State Hospital. She's doing great. I won't give you her name because she is terribly ashamed of everything that she's done for the past 10 years, and she wrote me a letter and asked me, Mom, when you testify, please don't use my name. But she has a treatment team. She is on 10 different group therapy things. She has just the best. The doctors, everybody said, this is absolute state-of-the-art. They said, you cannot get better treatment in California than what the Department of Corrections is giving my daughter. Why did my daughter have to become a criminal to get this kind of care? She shouldn't have had to do that. Back in 1990, she was in the hands of the hospitals, and everybody knew she was paranoid schizophrenic then. She's going to kill somebody. Actually, she's going to kill her ex-boyfriend's wife if she is released again, and today she was staffed down there. They're going to decide if she's going to be released in 4 weeks. So what are we going to do here? Are we going to continue stigmatizing the mentally ill, continue making it so they can't have a life, a good life like what we have? She'd like to have that. I'll tell you something. If I had the time, I'd read you some of her emails here. She has begged to be treated. But when she's psychotic, she doesn't know that she needs it. So why in the world should she be expected to make a rational decision when she's in an irrational state of mind? I just beg you folks, please, to pass AB 1800. And if you get nothing else out of my comments here, I just want you to remember this, that mental illness is a biochemical disorder. It can be treated. Treatment works. I'd like to repeat that 100 times to each one of you. Treatment works, and I've got my daughter back so long as she's in the hands of the Department of Corrections. Recovery is possible. And if you pass AB 1800, they say, as California goes, so goes the nation. You're going to be setting an example for the whole nation that we are no longer going to stigmatize the mentally ill, but we're going to give them the treatment that they so much deserve. So please, I'm begging you.
Okay, thank you very much. Members, before we move on to other witnesses, we need to just take up one item real quick. We're going to lift the call on item number 7, SB 817. If the Secretary would please call the roll of the non-voting members.
Corbett? Aye. Corbett, aye. Runner? Vincent?
Okay, members, that bill has 6 aye votes. We'll replace the call. Okay, thank you very much. Members, any questions of the witnesses? Okay, seeing none, then we'll bring up opposition witnesses.
Thank you. I would like to thank particularly Supervisor Brown for coming from San Francisco today, Dr. Lieberman from Los Angeles, and Ms. Warner from Sacramento. Her story about her daughter is very compelling, and you have pictures of her daughter.
Thank you, Ms. Thompson. We have 2 opposition witnesses, and then I also understand Katherine Kemp, who's California Association of Mental Health Directors, is here. She's in a neutral position, but wanted to speak on behalf of mental health directors. I guess we'll start ladies first. Catherine?
Thanks. As you say, I'm Katherine Kemp. I'm representing the California Mental Health Directors Association. We are neutral on this bill. I want to make really clear that we don't want to be characterized as opposition because we're as part of the second half. We're neutral on the bill. We wanted to share with you an experience that the county mental health directors, along with the State Department of Mental Health, local mental health boards, the California Mental Health Planning Council, and the Institute for Mental Health conducted over the last year. Out of concern in part about the contentiousness and controversy that this issue represents, we conducted a year-long exercise that consisted of 2 parts. The first part was a series of local forums. We held 29 forums in different communities around the state. They were professionally facilitated, and we heard during the course of those forums from 2,200 people. The purpose was not to comment on or take a position on a specific proposal about involuntary treatment. It was rather to gather information about the various interests and viewpoints. We heard compelling personal testimony from consumers, families, providers, and community members about their experiences with serious mental illness in both the public and the private system. We heard stories from consumers and family members about the difficulties they had getting access to care, receiving inadequate care, and the terrible consequences to individuals and their families when care is not available or not accepted. We heard about the problems that are faced by some particularly needy groups like the homeless, people that have a co-occurring substance abuse disorder, and other hard-to-reach groups. We heard about the unequal application, that whether or not you get accepted into involuntary treatment can vary county to county, depending on local judicial decisions and access to local services. We also heard very moving and positive stories from individuals who had received services that led to recovery and to their ability to assume full lives in the community. As you've heard from other witnesses, and you'll hear from more, treatment works, and when it's available in the right amount and at the right time, it can permit people with very serious disabling illnesses to live full lives in the community. The second part of our process was to try to find whether among the various groups in the mental health field there was common ground on the issue of involuntary treatment. As you can see before you and you've had in front of your office, there is no such common ground. We were not able to find agreement on the basic question of whether the involuntary commitment system should be changed or not. Families were frustrated, I think, by this, so were consumers, by the fact that we weren't able to agree on a particular course of action about the LPS Act. We were, however, able to find common ground that there are a variety of problems in the mental health system, and there are solutions that all of us, whatever side we are on involuntary commitment, believe can resolve some of those problems. I've given you a brief summary of some of those proposals. I'll just tick off the headings today. If you'd like more information about these 2,200 folks and what they had to say, we'd be delighted to provide you with lengthier summaries of both the local forums and the statewide forums. Access is a consistent problem. As you can see in your paper, we believe that some of the areas that do reach consensus that can help resolve problems of access to treatment include funding in every community, psychiatric emergency response teams. We believe that treatment plans at both the point of admission and the point of discharge for patients are too rarely available and should be funded and available to every person with serious mental illness. And we think that substance abuse services are extremely inadequate in California, including for persons with mental illness. We believe that families in the mental health system are often excluded, inappropriate, and we think particularly when somebody reaches the stage of an inpatient care that families must be included in planning where the consumer is willing to include them and offered more helpful information. Often in the name of confidentiality, they're excluded and barred from the process. We think that California's use of long-term care services is particularly inadequate, and we think as part of nursing home reform, we hope together with you this year that we will be able to improve the funding and the services that are available in nursing homes that treat the mentally ill. And finally, we hope that we can work with you to address uneven application of involuntary treatment so that the way you are treated is less uneven across the state. Thank you for letting us share our experiences with you, and we look forward to the improvements that we're all going to make together in the mental health system this year.
Okay, thank you very much. Next witness.
Good afternoon, Mr. Chairman and members. I'm Paul Garowitz. I am the Legislative Director of Protection and Advocacy Incorporated, an advocacy group for persons with disabilities. I also represent a coalition of groups called the CARES Coalition, advocating for rights, empowerment, and services. Other members of the coalition are the California Network of Mental Health Clients, the California Association of Mental Health Patients Advocates, and CASRA, the California Association of Social Rehabilitation Agencies. In respect to the committee's limit of 2 to a side, we've chosen 2 speakers. I'm going to be one. The other is Dave Husini, who's going to be speaking on behalf of CASRA, who's sitting over here to Assemblymember Thompson's right. and I would like him to start, but I just wanted to let you know that I also have Kim Lewis, who's the president of CAMFRA, and Sally Zinman is the executive director of the California Network of Mental Health Clients, to answer any questions that anyone might have that I and my limited abilities may not be able to answer for you. So this is Dave Husseini.
Thank you.
Okay. Thank you very much.
Thank you. I'm Executive Director of Consumer Self-Help here in Sacramento and the Office of Patient Rights in Sacramento. I'm also active in CAMFRA, which you heard about just a second ago, and the California Network of Mental Health Clients, who, after all, these changes are all about. I'm here today, though, to talk about CASRA. CASRA, the California Association of Social Rehabilitation Agencies, since 1978 has been the largest statewide association of mental health providers. The association currently has 38 member agencies from all around the state, and it employs persons from every discipline in the helping professions, including psychiatrists, psychologists, social workers, consumers, and paraprofessionals. The programs of the association serve approximately 50,000 mentally ill Californians every year. The member agencies of CASRA are strongly opposed to this bill. What you'll find around the state is that people who really know mental health practice and reality are in strong opposition to this bill because we know that it's the wrong answer to the common problems that we face. A friend of mine, Bill Compton, who's here in the audience, is the director of Project Return, The Next Step, which is a client-run network of 73 self-help clubs in Los Angeles. He had a small statement that I thought was really important. He says that nobody wants to be sick. Every day I was on the streets, I looked for help. I went first to the shelter in West Hollywood, which told me I had to go to Hollywood Mental Health 4 miles away. I went to West Hollywood's sheriff's station when no one came to the desk, but a voice from a loudspeaker told me to leave the building. I went to the county hospital where I slept on the floor. I then went out to the street and stood in front of a bus. When I finally got help, it was because an unlicensed board and care owner took me in and reconnected me with my family, but it was after 9 months. I would like to say, Bill says, that there are more services for mentally ill available now than there were 8 years ago. The truth is there are not. The Steinberg bill is finally funding services. On the other hand, and this is AB 1800 only offers more of the same intentions that put me on the street in the first place. Most notably, forced treatment where one doesn't even know what medication they're taking. It will also further overburden the hospitals, making it even harder to find a bed and take the much needed funds that should go into community programs and put them into hospitals where they're not going to do much good. People who really know mental health, the people who make up the CASRA agencies, which serve those 50,000 people a year, know that in order to improve our mental health system, we need to expand the array of voluntary services available to clients and families. We already have mechanisms within the current LPS to deal with the question of involuntary commitment. Also, I'm a patient rights advocate. I don't know where it comes from that past history is not included. Past history is certainly included in every patient rights hearing I've ever been to. We already have mechanisms to take care of involuntary commitment. What doesn't work about this bill are many, many things. One of the things that doesn't work, it flies in the face of everything we know about mental health care and treatment. Coercion and the punitive nature of these proposals are going to be very detrimental to what they're trying to accomplish. As knowledgeable providers of mental health services, we know that these proposals would cause people to be fearful of services. They would drive more people away from services. They would increase homelessness and instability, not fight it. I'm sure, we've all heard the tragic stories of family members and others who support this bill, but for each one of those stories, I could tell you more about people afraid to access the system because it's too coercive and punitive the way it is right now. These proposals do not promote trust. Indeed, as we know, the large majority of mental health consumers are tremendously vigorously opposed to these proposals. As you know, the clients in CASRA are not alone in opposition to this bill. And the reason for that is, with all due respect, it is a very bad bill. It is a harmful bill. It is a poorly written bill. It's a bill supported only by really a small group of people who have had atypical experiences with the mental health system. You know, when I heard today that you weren't going to vote on the bill, I mean, maybe this is the way bills always are, but this is such an important thing to us, to those of us who are opposed to it. You know, it was introduced as a spot bill, then it was withdrawn, and then it was put back, now it's withdrawn, now you're not voting. I mean, it reminds me of buying a used car. You know, eventually you got to say the car's no good. Don't buy that car. And so I hope you don't. What we do want are the programs of AB 34 by Darrell Steinberg, which have already gotten over 1,700 mentally ill Californians off the streets voluntarily. I work closely with Turning Point Community Programs here in Sacramento, and I can tell you that the reason they work is because of their can-do attitude. They will do whatever it takes to gain the trust of people, and in so doing, I can testify to you they have reached people who 6 months ago were said to be unreachable.
Sir, I need you to wrap up your testimony.
Thank you very much.
Thank you, Mr. Speaker, because I did have a witness who had to condense 15 minutes of her testimony into 5.
And I will conclude very quickly. Thank you.
No, sir. We're gonna have to stop you here. You've gone way past your time.
Oh, okay.
In fairness to all the others, if we can just. Oh, yes, Ms. Kuehl.
I just wanted to ask, as a committee member, if you could instruct the people who are here visiting that we don't generally hiss or clap or do those kinds of things at committee hearings. Many of them may not have been at a hearing before, but the committee would really appreciate it if you wouldn't do that.
I think that was a message well delivered, Ms. Kuehl. Thank you. If we have other opposition witnesses, just please come up to the microphone, state your name briefly, and...
Yeah, Paul is next.
Mr. Chairman, I'll be very brief. In my testimony, I think Dave has really covered...
Well, excuse me, but haven't we had two?
No,
we've not had two. Oh, okay. Is this the second opposition witness?
Ms. Kemp was the neutral.
Okay. Sir, go ahead then.
Okay, thank you. I will be brief, or do my best to be brief, and welcome you to stop me if I go too long. I would like to start off by echoing a theme that Assemblymember Thompson began her presentation with when she spoke of liberty and said that it's a cruel form of liberty that allows people to struggle homeless on the street without help. And I think that we all agree with that statement. The disagreement is what to do about it. There are currently pilot projects in this state that were created by Darrell Steinberg's bill of last year, AB 34. My understanding is hundreds, literally hundreds and hundreds of homeless people have been non-forcibly, voluntarily helped by that bill through outreach programs. And when approached in a non-coercive, non-forceful way, well over 90% of those approached have voluntarily agreed to seek and receive help. This tracks very closely with the experiences of Mr. Compton, which were described to you by Dave a moment ago. Many, perhaps most, if the Steinberg bill experience is accurate, over 90% of those who are homeless and in need of psychiatric services would gladly receive them voluntarily if they were approached in a non-threatening, non-coercive, voluntary manner and brought in as partners in their own treatment. That would be consistent with both actual liberty, liberty being that which our country was conceived in, and also would be the kind way to approach them and would provide services for them. The witnesses have testified that persons with mental illness have something wrong with their brains and therefore cannot make decisions in their own best interest. And I will repeat what Ms. Kuehl said and ask that there not be demonstrations when I say this, but there are probably over 100 people in this auditorium who would strongly disagree with that statement, who every day make decisions on their own despite the fact that they have been diagnosed at some time in their lives with a major psychiatric disorder. They make those decisions every day. If the decision means taking medications, when they are partners in that decision to take medications, they take them. When they feel they don't need them, sometimes they don't take them, and many of them do just fine. Some of them are in therapy. There are a whole variety of systems involved in helping people maintain their lives, none of which, in the case of the people I'm talking about, involve force, coercion, or involuntary treatment. That being said, the main points of this bill that we have problems with, besides the fact that we think that voluntary treatment works and involuntary treatment doesn't work, is that we think that the bill is very possibly an unconstitutional incursion into civil liberties. Variety of points on that. I heard the beeper go off. It's thank you, Laura Lynn, and all of those points are covered in Ms. Blackwood's very able analysis. So I will just once again thank the committee for giving us the time to speak here today and make myself available, or my colleagues, for any questions that anyone might have.
Thank you. Are there any questions of the witness from committee members? Are there any more opposition witnesses who wish to speak? We had two, and I understand the other side had three. Yeah, we do have, you come up and you can add your Me Too's.
It's a Me Too. Don Pearson with the Citizens Commission on Human Rights, and we are in opposition to the bill and support the testimony that occurred today.
Thank you.
Carl London, representing California Psychological Association. We appreciate Ms. Thompson's statement about fixing the turf issue that's in the bill and look forward to further discussion on the bill. Talk to you later.
Thank you.
Since I couldn't speak as an opposition witness, Sally Zimman, representing the California Network of Mental Health Clients, and I have to say over 2 years, 2 client forums, 4 surveys, the vast majority of the clients of the state oppose this, for whom the bill is supposed to serve.
Linda Lagatetta, Realtor, strongly opposed to AB 1800. Thank you.
I'm Elaine DeRush, a mental health client, very much against the whole of AB 1800 because expanding forced treatment is destructive and doesn't work. And I am hopeful for SCR 59 to lead to voluntary comprehensive community services with wraparound and recovery goal in mind.
Thank you. Any more Me Too's?
My name is Gaines Lyons. I'm the editor of Next Step News, which is published by Project Return. For all the talk about the...
Mr. Gaines, we're not taking testimony. Just enter your opposition or support of the bill. Are you in support? You're in opposition to?
I oppose the bill because it doesn't say anything about how science is going to be applied. Yes, the science is there to benefit mental health consumers, but it says nothing about how this latest advance in scientific therapy is going to be applied.
Thank you.
I'm Bill Compton. I'm Director of Project Return the Next Step. I'm also on the Board of Directors of the California Network of Mental Health Clients and Pacific Clinics. I am opposed to AB 1800 because it is about maintenance instead of about recovery. For recovery, the client needs to be a voluntary partner in his treatment plans, and AB 1800 doesn't provide that.
Before we have another witness, you'll notice the line and the time is getting late, so we'd like you to enter on the record your name and in support of or in opposition to, and ask that you abide by that so everyone has a chance to record their presence here today and their position.
Ms. Bates, since we did not do that with the supporters of the bill, when the opponents are finished, I would like to call forward those who support the bill as well.
Moving forward.
I'm Elnora Cozy, and I'm opposed to AB 1800 because it's not going to be for the people of color, and as a Black American, I feel that that would be unfair.
My name is Pearl Johnson. I'm from Los Angeles, California,
and I'm representing the National Association of Rights, Protection, and Advocacy. After 51 years in this system, I'm 70 years old now. I not only oppose, I hope you oppose AB 1800.
Thank you. Next.
Ms. Denise Kate, and I oppose the bill, AB 1800, because it did not work for me. Thank you.
Thank you.
I'm Lisa Bruce. I'm from Concord, California, and I oppose it. Give us our dignity. Thank you.
Is this alive here? Okay. I'm Ted Chapasinski. I'm Directing Attorney of Mental Health Consumer Concerns in Concord, California. We're the patients' rights advocates for 3 counties. And this change in the definition of grave disability, I know from doing thousands of hearings, is going to mean we will no longer be able to defend clients at hearings, and you might as well do away with these hearings if this definition of grave disability goes into effect. And so
You
for
are
that
in
as well
opposition, sir?
Yes, for that as well as other reasons, I'm opposed to the bill.
Thank you. Yes.
My name is Douglas Hammond, and I'm opposed against it because we as the people, as the consumer, know what's better for us than Helen Thompson, who is not a mentally ill person. She should be locked up.
Next.
There are times when I do wonder about my sanity, frankly.
Excuse me. I would just want to say with regards to the statement that was made by the last witness, I have run this committee for 4 years and have always held to the highest standard of courtesy and professionalism. Regardless of the position that you have on a bill, I expect the highest decorum in my hearing room. And hearing rooms, by the way, for chairmen are like courtrooms for judges. And I can have this room emptied out by the sergeants at my request. So please don't have me do that, but please treat everybody here with the dignity and the respect, the courtesy and the professionalism that they deserve. It's the least that we can request, especially in a public forum.
My name is Kathy Zatkin. There's one tenet of medical ethics with which no one disagrees. The first tenet is do no harm. I'm asking you to vote against this bill because it would be state action where we know there are substantial harms to certain treatments that would probably be forced. Thank you.
Walter Schway from Davis. I'm strongly opposed.
My name is Janie Anker. I'm the president of Mental Health Consumer Concerns. I'm a product of forced treatment at Napa State Hospital. It does not work. I still have residual effects from that forced treatment, and I have hundreds of petitions signed by consumers, providers, and family members opposed to 1800.
Thank you. Sir?
My name is Bruce Windrum. I'm the former board chair of Oakland Independent Support Center, an information referral and advocacy drop-in center for people who are homeless, have been homeless, or are at risk of being homeless, who are labeled mental or have been through the mental health system. And I am strongly opposed to this measure because it is discourteous.
Thank you.
My name is Mark Spratt. I represent the Jesuit Volunteer Corps, and I'm strongly opposed to this divisive bill.
Hi, I'm Sarah Cohen. I'm a patients' rights attorney at the Mental Health Advocacy Project of Santa Clara County, and I'm registering my opposition to the bill.
Thank you.
My name is Claudia Arellanes from Consumer Self-Help North Center, and I appreciate being here today to hear and see how the system works or doesn't work, and I oppose AB 1800. Thank you.
Thank you. Yes, next witness.
My name is Nancy Thomas. I'm the director of the Alameda County Network of Mental Health Clients, and I oppose this bill because I think the money that's attached to it could be so much better spent with voluntary community treatment services that are available and voluntary. Thank you.
Thank you.
I am Sharon Ferguson. I'm speaking for myself and others whom I have talked to that have gone through mental health, and all believe that, in fact, the voluntary does work better, and then, too, with the rehabilitation, helping to get jobs, whatever else, and working with the family, works far better than forceful treatment that even now is allowed, and then after the 12 days can even take another 12 days after a hearing.
Thank you.
After
Thank you very
initial
much.
3.
Just
Thank
please
you.
state your
I
name
did,
and your
I'm
position for
opposed.
the record. Thank you. Sir?
Yes, my name is Dave Smith. I'm a counselor at a drop-in center, and I'd like to thank all of you for your tenacious examination of this. I am in opposition of 1800.
Okay, thank you very much. Let's move on to the next witness, please.
My name is, excuse me.
Just press the
My name is David Keys. I spent 5 years in the state mental hospital system to the tune of $2 million taxpayers'
Sir,
money.
just state your position on the bill for the
And my
record.
position is totally against it. If the
thank you
doctors
very
had
much,
listened
sir.
to me, I
Let's
could have
move
been
on to
out
the
in
next
half
witness,
the
please.
time. Thank you. My name is Brian Brack.
Sir, I need you to press, there you go. Thank you.
My name is Brian Brackney of Oakland, California. I am opposed to the bill.
Okay, thank you very much. That's all we need to hear.
Hi, I'm
Yes,
Donnie
thank-
Matthews, and I oppose the bill strongly.
Thank you.
I'm for this.
Connie Barker, California Psychiatric Association, in support.
Okay. Donna.
Donna Seitz, representing Los Angeles County, in support.
Marianne Bailey, Union of American Physicians and Dentists, in support.
Thank you.
I'm Evelyn Fallon, the parent of a gravely disabled young daughter, and I'm strongly supporting this bill. Please help us.
Thank you.
I'm Heidi Sanborn. My mother's schizophrenic. I strongly support the bill.
Thank you very much.
Chuck Sosby, California Clients for LPS Reform.
Thank you.
Grace McAndrews, Executive Director, NAMI California, in support.
Hi, my name is Sheila Hansen. I'm with NAMI Sacramento. I have a son that's bipolar schizoaffective. I also have a sister who's bipolar schizoaffective, and I strongly support this bill.
Thank you very much.
Randall Hager, representing the California Treatment Advocacy Coalition, in strong support.
Carla Jacobs, representing the Lanterman Petrus Short Reform Task Force and the National Alliance for Mentally Ill National, in strong support.
Thank you.
My name is Mike Wheeler. I'm the Program Director for Consumer Self-Help North Center, and I'm strong opposition to this bill.
Okay.
My name is Lynn Donahue. I'm a parent of a schizophrenic son. I'm a longtime mental health research consultant, and I'm currently with the Journal of NAMI California, and I'm in favor of 1800.
Okay, thank you. Steve?
Steve Thompson with the California Medical Association. We had members that participated in the deliberations, the town hall meetings, and while we think the definition of
My name is Martin
conservatorship could be
Schwartz.
tightened,
I'm,
we are in support of this legislation.
Okay. All right. Thank you,
Okay.
Steve.
Get a twofer.
All right. We got both of you.
Yeah, my name is Martin Schwartz. I'm from Sacramento. I totally oppose it. Thank you.
Okay, thank you. Any other opposition or support witnesses? Okay, seeing none coming forward. Members, any questions of the author or the witnesses? Okay, Mr. Wayne and then Ms. Kuehl.
Just very briefly, I understand that this vote will not be taken today and will be considered. I know that there are a number of other bills also dealing with mental health, and I think that the whole area needs to be dealt with comprehensively. And I would request that the chair bring those other mental health bills up for hearings at the same time that this bill will be heard again.
Okay. Thank you, Mr. Wayne. Ms. Kuehl?
Mr. Chairman, I'm not sure how this really fits into the hearing, but as the chair of the Judiciary Committee, I'm very concerned, although the Health Committee has done an admirable job in analyzing the issues that relate to the health concerns related to mental health treatment and whether this is a good or a bad idea. There are a number of civil liberties and civil rights issues that, including constitutional issues, that I feel need to be more fully developed, analyzed. I mean, this is a very, very important and new issue. Therefore, I will be voting for the bill, just so advocates and opponents know, with the hope that this bill will pass to my committee for the next hearing, in time for its hearing sometime in April, so that we can fully develop the other side, not the other side, but the other half of these issues that have to do with constitutionality and civil liberties issues.
Thank you, Ms. Kuehl, and certainly we're going to make every effort to address the concerns of the Health Committee here. As you may or may not be aware, we're not voting on the bill today. We're putting the bill over, and we're going to work as diligently as we can on the amendments that we feel are important to this bill, and going to make every effort to see to it that it does get to judiciary on time, so that your issues can also be dealt with in that committee. Okay. With that, Ms. Thompson, would you like to close, address some of the remarks that were made by the witnesses?
I would be very happy to do that, Mr. Chairman. I appreciate your patience. First of all, I'm going to answer, I believe, some of the issues that were raised. Managed care will keep the costs of inpatient services down. The average stay on an inpatient level, even as an involuntary patient today in the Sacramento region, and I think it probably reflects statewide, is less than 5 days. In fact, it's about 3.5 days. So that's one issue. Past history cannot be considered when people are on the street and need to be brought in a timely manner. The system currently does not provide outpatient services to involuntary committed people. All the need for improved services we all recognize, and in fact that's why the President Pro Tem and the Speaker of the Assembly set up the Joint Committee on Mental Health Reform so that we could look at the need for increased services. But those increased services are only for those who will accept them, and we've heard various testimony here today. This bill is not about them. This bill is about those who refuse service because of their illness. I want to say that I appreciate very much Katherine Kemp's presentation. I read the 40 local meetings statewide. I read all of their reports, and I have to say that no, there was not consensus on the LPS, but there were many suggestions made by family members and clients and law enforcement officials and many others who had some good suggestions to make about changes in the LPS law. While the system of 72-hour holds, 14-day holds, one-year conservatorships, and the criteria for involuntary treatment are complicating and confusing, it is important to understand that this bill is very limited in its scope. It is very important to understand what the bill does and what the bill does not do. First, the bill leaves almost all of the existent 30-year LPS Act intact without change. Most of the opposition to the bill opposes all involuntary treatment, not just the changes to the involuntary treatment criteria or some of the other changes we've made in this bill. Second, the bill makes no change in the area of due process. Like Supervisor Brown, I was born in the civil rights movement as well, and I understand those issues, having been the only Caucasian nurse in the Washington, D.C. office serving the downtown community prior to the march of Martin Luther King. Much of the difficult decisions that are made will continue to be made in the judicial hearings, with patients afforded all of the same advocacy from public defenders and other attorneys, and with the same procedural rights they now enjoy. The bill does revise the factors the court may consider when it is determining when involuntary treatment is best for a patient. It allows for the consideration of the patient's history of severe mental illness. It seems unconscionable to me that we would want to make a medical determination without considering the complete medical history of a person. But simply prescribing treatment isn't enough. Providing more voluntary services is not enough. Providing more insurance coverage isn't enough. In fact, for the individuals we're talking about, those who refuse treatment despite all offers of treatment, these services don't even begin to scratch the surface for that segment of the population. Now, my quote was, and I want to make sure you understand it clearly, "It is a cruel distortion of the concept of liberty to leave seriously mentally ill persons untreated, to fend for themselves, and to end in our jails and prisons. The ultimate coercion, in my opinion, is represented by the fact that we have 8% of our severely mentally ill in our jails and 18% in our state prisons. When you listen to the family members and hear the pain they go through, when they ultimately make the decision to seek a conservatorship for a loved one, you understand this is not done easily. It never will be, nor should it be done easily. But it is a very painful process for a family. The only easy thing we can do is turn our backs on these patients, abdicate our responsibilities, and walk away, and that's what we've been doing. That's the easiest way out, and that's what we currently do. It's what we're proposing to do. You heard a lot of testimony, leave the system as it is, just bring some more voluntary services in, and that'll take care of the problem. Well, sorry, but it won't. We should be ashamed of the fact that we've turned our back on these people. I'm ashamed. When we feel shame, it's only natural to hide that shame. And we hide behind the shame by righteous arguments of protecting the individual's civil rights, including the right to destroy oneself and others. We hide that shame behind pledges of millions more dollars for voluntary treatment and self-help programs and all the other unmet needs of the mentally ill. And as important as those programs are, and believe me they are, and believe me I know a lot more about them than people give me credit for, we hide our shame behind them, knowing they will never reach many of the people who need them the very most. We can continue to hide our shame, but the shame will not go away. In a sense, this bill puts you in the same dilemma as a loving parent of a despondent schizophrenic adult child on a path of self-destruction. After all else has failed, after episode after episode, after repeated 72-hour stays in jail, 1 or 2 week stints in the local locked facility, followed by more episodes, breakdowns, threats, and complete despair, do you seek help from the state or do you walk away? That is your decision. I apologize for putting you in this position. It's uncomfortable. Many people have asked me, why are you opening up this issue? This issue needs to be discussed at the public level. It needs to be debated, and we need to make some decisions. Like it or not, while it's uncomfortable, we're already in the position of needing to make those decisions. The bill simply forces us to face the problems. In a sense, the bill also puts us in the position of someone who needs involuntary treatment. We don't want it, we don't enjoy it, but it also provides us a pathway towards recovery. And recovery is what I believe in. I believe that mentally ill people can be treated, they can recover, and they can be productive human beings, just as you have heard from many people here today. However, I still think about the people I see when I visit the state facility at Vacaville. Severely mentally ill individuals who along the way we have turned our backs on. In the end, we only have two choices. We can continue to abandon these severely injured people and hide our shame, or we can step up to the challenge, and challenge it is, and meet our responsibility to find the way to let people who need help access that help. It's not pleasant, it's not easy, but it is the right thing to do. And I would ask for your support of this bill. Thank you.
Thank you, Ms. Thompson. Members, without objection, this bill will be put over to a future committee hearing, at which.
Mr. Chairman, to advocate that the hearing be the one in March at the end. I do not agree with Member Wright on that issue, but we can argue that perhaps a little more.
You're referring to March 31st, which would be the last hearing in March? 28th.
28th.
Okay.
That then allows me the the opportunity to negotiate the amendments with you in the Health Committee, and gives me the time to get to the Judicial Committee to deal with the judicial issues.
Okay. Well, we'll make every effort, though I can't commit to that. We will work with you diligently on the amendments to that bill. Thank you. Members, if there are no further comments, we have one item left. We have one call that we need to lift. That's on SB 817.
Item 7.
Item number 7. Will the Secretary please call the roll of the non-voting members?
Runner?
SB 817, Mr. Runner?
Runner, no. Vincent?
Absent, yeah. Okay, members, that bill has 6 aye votes, and the author's office has requested reconsideration without objection. Seeing none, reconsideration will be granted on SB 817. We'll hear that at a subsequent hearing. Members, that concludes the business of today's hearing. Thank you all very much. Our hearing is adjourned.